All right, so welcome to PIC University. My name is Tom Weiler, and I'm a pediatric intensivist. And I'm going to talk to you today about low cardiac output syndrome. So, uh, the content of this talk was inspired by a couple of podcasts that I would recommend everybody take a look at. The first one is called Healing Hearts, and that's put out by Dr. Laura Ortman at Children's in Omaha, Nebraska. And then additionally, there's the PCICS podcast put out by the Pediatric Cardiac Intensive Care Society. And they have an episode in their series called Milrinone Trash or Treasure. So I highly recommend you check out both of these podcasts as they refer to some of the topics I'll be discussing today, as we hope to draw on that information and go a little deeper in some of the aspects. So before we get into low cardiac output syndrome, I'd like to discuss something I'd like to call normal cardiac output syndrome, and that's essentially the components of cardiac output. Now, cardiac output is the blood ejected from the heart in a unit of time in a minute. And essentially, it's determined by three major factors. The first one is preload, or how much blood is filling the heart during the diastole part of the cardiac cycle. The second is contractility, which is the squeeze of the heart, or how much it contracts with each heartbeat, and how much blood it can eject because of the force of that contraction. And then the final thing is the afterload, and that's the force against which the heart is pumping in order to eject blood into the bloodstream. And so when you put these things together, you make up the stroke volume. You have the aspects of preload, contractility, and afterload, and they all determine the stroke volume, which is the amount of blood ejected with each heartbeat. So stroke volume times heart rate equals cardiac output. And so with that, we can look at the syndrome of low cardiac output. And so the definition is basically a constellation of signs after cardiopulmonary bypass that indicate temporary cardiovascular dysfunction and decreased systemic perfusion. And so I have vascular underlined because I think that's an important aspect of this picture that we'll get into a little bit. But to break it down more simply, the cardiac output of low cardiac output syndrome is essentially composed of systolic and diastolic dysfunction. So it's not just a problem with ejecting blood and the amount of squeeze getting blood out of the heart, but additionally, you can have difficulty filling the heart, letting the heart relax, and fill with blood during diastole. So that's an important thing to keep in mind as we're thinking about therapies for this syndrome. Looking at vascular malfunction that occurs in low cardiac output syndrome, it's best characterized by both increased SVR, so systemic vascular resistance, against which the left ventricle works, increased pulmonary vascular resistance, that is what against the right ventricle works, and capillary leak, so the loss of plasma and fluid from the bloodstream into the interstitium. And so all these factors have to be considered when treating low cardiac output syndrome. So this understanding of low cardiac output syndrome fits nicely into our understanding or our framework of cardiac output. So determining preload, you have the issues of diastolic dysfunction and capillary leak, which definitely affect your preload. With regards to contractility, systolic dysfunction is an issue with contractility. And then afterload is determined by your systemic vascular resistance and your pulmonary vascular resistance. So who is at risk for low cardiac output syndrome? Well, essentially, the literature says that patients who are at a young age are more likely to suffer low cardiac output syndrome after cardiopulmonary bypass. So that's neonates and babies are more at risk than school-age children and teenagers. Additionally, patients that undergo a long cardiopulmonary bypass time are more likely to have low cardiac output syndrome. And then finally, those patients that have pre-op cardiac dysfunction, so those patients that are in heart failure for some degree of time before they get their corrective surgery, are more likely to have low cardiac output syndrome after surgery as well. So what causes or what is the mechanism of low cardiac output syndrome? So essentially it's understood as an inflammatory process, and that process is triggered by the foreign material of the cardiopulmonary bypass circuit coming in contact with the components of our blood. And so this essentially activates the immune system, which is composed of platelets, complement pathway, can inhibit things like nitric oxide, and it's this activation of the immune system that kind of determines the timing of low cardiac output syndrome. So those that know, those that have taken care of these patients will know that low cardiac output syndrome usually occurs about 6 to 12 hours after cardiopulmonary bypass. And it can last up to 24 hours. And that's because it takes a while for these immune regulators to ramp up to be activated. And so that's why we don't see it immediately. These patients tend to slump later in the evening, have their post-pump slump, as it's colloquially known, on the first post-operative night. So in addition to the inflammatory process that's occurring, these patients have also undergone some degree of myocardial ischemia during aortic cross clamp during their cardiac surgeries. And so certainly having suboptimal perfusion to your heart muscle can lead to decreased function. We know that from seeing how these patients react after surgery. Additionally, we have to understand that patients who have low cardiac output also may have some residual effects of cardioplegia. Now, cardioplegia is usually reversed at the end of surgery, but there is thought that there is some residual effect of that cardioplegia in patients who are experiencing low cardiac output syndrome. So that's an important consideration to keep in mind as well. And then finally, and perhaps most intuitively, is the fact that some heart surgeries involve cutting the heart. So a ventriculotomy, cutting that main pumping muscle of the ventricle, can certainly decrease your cardiac output, as a cut muscle does not function as well as an intact muscle. And so that can sometimes be one of the root causes. So, as I said, the clinical presentation of low cardiac output syndrome usually occurs 6 to 12 hours after cardiopulmonary bypass. And what it looks like at the bedside is usually first notable for tachycardia. So, these patients, because of the factors of effect on their preload, their contractility, and their afterload, the patient will have a decreased stroke volume. And so, in order to compensate for that, the patients with LCOS will increase their heart rate in order to compensate. And that makes sense. You're trying to maintain your cardiac output and your stroke volume is lower, so you have to have a higher heart rate to compensate, to get oxygen and blood to your vital organs. Additionally, you may see at the bedside shunting to your vital organs away from quote unquote less vital organs. And that less vital organ we're referring to is the skin. Essentially, skin and tissue are kind of a window into the perfusion, the peripheral perfusion of the body. And so when a patient is trying to judiciously kind of triage where blood needs to go, where oxygen-rich blood needs to go, we will essentially shunt blood away from the skin, those vascular beds, interior into the body, and to perfuse better the heart, the lungs, the liver, the kidneys, and the gut, and those vital organs, not to mention the brain. So what that looks like clinically is you have a patient that's either pale or clammy or cool or mottled, whatever word you want to use, tepid. That's what those patients look like peripherally at the bedside. And that is corroborated by the information we get from some of our monitoring devices in the form of regional oximetry or near infrared spectroscopy. So these are measures of kind of mixed oxygen in arterial, capillary, and venous blood. And those will definitely go down, and you'll see a trend downwards in those NIRS readings as patients are developing low cardiac output syndrome postoperatively. So how else do we diagnose low cardiac output syndrome? Well, there's a few lab tests that people like to point at to evaluate how their patient is doing. And the first one I want to discuss is mixed venous oxygen saturation. And so the mixed venous oxygen saturation is essentially a global measure of the amount of oxygen in the blood returning back to the heart, returning back to the right side of the body, right side of the heart before it gets reoxygenated again. And so this can be decreased either because you're not sending enough oxygen out to the body in the first place, or you're having higher extraction relative to the amount of oxygen that's being delivered. And so normally we expect to see a difference between the arterial oxygen saturation that measured on your pulse ox, or your arterial blood gases. We expect to see a difference from that number to the mixed venous number of about 25%. And if that delta starts to creep up above 25%, then you have a sign that maybe you're delivering less oxygen to those tissues in the first place, or perhaps you're having more extraction of oxygen on the back end. And so we like to watch that number very carefully and see if the delta of the mixed venous oxygen saturation is increasing. And that's a global measure of hypoxemia for these patients, and a good number to follow. Additionally, lactic acid is a very popular lab test for judging and taking care of these patients. And we traditionally think of lactic acid as a measure of anaerobic metabolism. When patients have a state of hypoperfusion where they're in low cardiac output, they may not be getting the adequate amount of oxygen to vital organs. And so things like skeletal muscle can start to produce energy in an anaerobic pathway. And one of the byproducts of that energy production is lactic acid. And so we tend to see this number go up when patients are in a in a more anaerobic state. And so that's a very important number to trend as well. However, that's not the be all end all, and there is a bit of a caveat to that number as well. And so lactic acidosis we know is very common in children who are post-op from cardiac surgery. And like I said, it's usually a marker of cardiac output and delivery of oxygen. However, there is a distinct cohort of patients who have lactic acidosis but have preserved cardiac output. And so this entity, which is sometimes called benign lactic acidosis, sometimes called type B lactic acidosis, occurs in about 23% of post-op pediatric cardiac surgery patients. And these patients generally have better hemodynamics than you might expect in the first 6 hours after surgery, especially compared to their counterparts that have lactic acidosis in the traditional sense. And so they may have lower heart rates, they may have less tachycardia, they may have lower CVPs. Additionally, they may have higher blood pressures and higher urine output, showing that their cardiac function is actually doing pretty well. And additionally, in terms of the timing of this phenomenon, they have an earlier resolution of their lactic acidosis. So there's studies that say that it resolves on an average of 16 hours versus 23 hours for lactic acidosis in the traditional sense. And so the mechanism can be ascertained by looking at kind of one of the other disease states we see that has a high occurrence of this benign lactic acidosis, and that's status asthmaticus. So these patients are usually receiving a lot of catecholamines in the form of albuterol, exogenous catecholamines. And additionally, if you have the misfortune of checking a blood gas on one of these patients, you may also notice that their lactate is high. And so these patients have high catecholamines. They may have high glucoses because of a stress response or perhaps the steroids that they're getting. And these are kind of the unifying features that kind of indicate that you're having a lactic acidosis of the benign variety. And so driven by hyperglycemia and catecholamines, this is what that pathway looks like. And for those that are really not fans of biochemistry, I've just tried to scale it down and kind of highlight the most important aspects of this pathway. So essentially you have plasma glucose, which can be, normal, high, or hopefully not low in your postoperative cardiac patients. And additionally, you have an abundance of catecholamines in that bloodstream as well. So you're having a patient that may have their own endogenous catecholamines in the form of epinephrine and norepinephrine because they're in a stress state. And also we're giving them infusions of catecholamines in order to help their cardiac function. So what both of these things are doing, either by just having glucose passage into the cell or glycogenolysis, liberating more glucose from liver and muscle tissue, is you have the production of pyruvate, which if in an aerobic environment can be converted into acetyl-CoA and ATP via the TCA cycle. However, even if you have an abundance of oxygen, even if you don't have a hypoxic state or hypoxemic state, some of the pyruvate may be shuttled into lactate, may produce lactic acid. And that's even in an abundance of oxygen, just because of the abundance of substrate that's happening from this pathway. So that's kind of the gist of that mechanism. And so that's why we see patients that have no hypoperfusion, have no hypoxemia in their tissues, and yet they have an abundance of lactic acid. So I think the takeaway from this kind of phenomenon is that it illustrates a good point for us, is that we need to rely on all the information at our fingertips in order to kind of ascertain how our patients are doing, and rely on the total picture in order to know exactly what's going on with them. Lactic acid is not the be all end all. If your lactic acid is high, you have to consider the other aspects of the patient's state before you kind of make a decision on how to treat them. Similarly, I just wanted to touch back to heart rate as well, kind of on that same vein. And that is to say that heart rate tachycardia is a very sensitive sign for low cardiac output syndrome. However, it's not necessarily a very specific sign. And what I mean by that is that heart rate can be kind of clouded by certain aspects of the post-op cardiac patient. Namely, you can have a slower heart rate when patients are receiving medications or have clinical conditions that slow down their heart rate, even though they may be in low cardiac output. For example, patients who receive infusions of dexmedetomidine, we know that's an alpha-2 agonist and can definitely slow down your heart rate and slow down your sinus node. So that's one way that the heart rate may not be a reliable indicator. Additionally, these patients who have cardiac lesions who also undergo hypothermia at times and who have sick or inflamed electrical conducting systems in their heart may have sinus node dysfunction. So it's important to know that sometimes your heart rate can be artificially low. And on the other side of the coin, your heart rate can be elevated for reasons that are not low cardiac output syndrome as well. So if you have any sort of tachyarrhythmia, apart from having low cardiac output, certain things like jet or any other automatic tachycardia, that can certainly make your heart rate higher than it would be otherwise. And then if patient has pain or agitation, that can also be a reason why your heart rate may be higher in the absence of low cardiac output syndrome. So these numbers, these lab tests or vital signs that we like to look at, the lactate, the heart rate, et cetera, we can't just rely on them in isolation. We kind of have to put the whole picture together. So moving along to how we think about prevention of low cardiac output syndrome. And as we said, it's a syndrome of temporary cardiac dysfunction leading to decreased systemic perfusion. And that cardiac dysfunction kind of has to do with the preload contractility and afterload. And knowing what we know about these aspects of the cardiac output, there's a drug that's very popular for treating patients with low cardiac output syndrome, and that's milrinone. So many people are familiar with milrinone as it being a phosphodiesterase inhibitor. And essentially what that means is that it increases calcium influx into the heart muscle cells of the post-op cardiac patient, especially helpful for those neonatal myocardial cells, because as we know, neonates have an immature sarcoplasmic reticulum, and they have a less ability to mobilize calcium and cause heart muscle contraction versus older children. And so it does that. It helps squeeze and helps mobilize calcium in those heart muscle cells. However, it also does a couple other things. It can vasodilate, so it can decrease both left ventricular and right ventricular afterload. And additionally, a unique property of milrinone is that it's known as a lusitrope. So lusitropy is a phenomenon or rather a characteristic of vasoactive medications, which improves diastolic dysfunction and allows the heart to relax and fill more easily. And so that's a really valuable characteristic in this medication. And you can look at these actions that it has. It improves contractility, it vasodilates, and it helps the heart relax better. And really, put into that framework that we discussed earlier, it seems like the ideal drug. Obviously, you can treat diastolic dysfunction, that's a plus. You can improve contractility, that's a plus. And you can reduce afterload, that's a plus. So really, it seems like the perfect drug. And that makes sense physiologically. So what is the evidence behind milrinone? So the primary paper that people will point to when discussing the usage of milrinone in this patient population is called the Primacore study. And that study is from 2003. And in that study, they looked at a cohort of infants who had a wide variety of heart surgeries, and they randomized them to three separate arms. The arms were a placebo group, those who received no milrinone at all, a low-dose milrinone group who received a bolus and then an infusion of 0.25 micrograms per kilogram per minute of milrinone, and those who received milrinone at 0.75. And so the takeaway from their findings was that the patients who received high-dose milrinone had lower rates of low cardiac output syndrome. And so that's reflected in their graph here. You can see that the percentage of patients who experienced low cardiac output syndrome went from 26% in the placebo group down to a non-statistical reduction in the low dose group, and then a statistically significant reduction in the high dose group, down to 9.6% of patients experiencing low cardiac output syndrome. And so that's exciting evidence. It seems to be case closed because we understand the physiology and we see that data. However, there's been some people that have been providing some interesting nuance to that evidence and reevaluating how we think about milrinone. And that's where I get to that podcast I referenced in our open. And that's from PCICS episode 109, which I'd recommend you take a listen to. It's definitely a good piece of information for us to think about. And so in that podcast, they really look hard at the physiological mechanism of milrinone and what they learned from one of the studies that this group did. And so the kind of impetus for this study was to see that, in the milrinone group in that Primacore study, they saw a significant reduction in blood pressure, shown in this graph, versus the control group. And additionally, they saw more tachycardia in those intervention groups. So patients had both more hypotension and more tachycardia when they received milrinone versus control. And so they additionally looked at the clinical signs that were determined as the primary outcome in the Primacore study. And as we do, the group in Primacore defined low cardiac output syndrome using at least partially clinical signs, which were tachycardia, oliguria, which is low urine output, poor perfusion, and cardiac arrest. And just to highlight a passage, that aspect about poor perfusion becomes really interesting and becomes a sticking point for this group in the PCICS podcast. And they essentially point out the fact that 72% of those patients in the Primacore study who were diagnosed with low cardiac output were done so because of cool extremities. So that's really interesting and kind of a good thing to point out, because the assessment of cool extremities is really a rather subjective one. There's good papers out there that tell us that we don't have good inter-rater reliability, and we don't agree very commonly about whether a patient is warm, whether they're cold, or whether they're somewhere in between. And there's data to support that idea that the assessment of a patient's perfusion is rather subjective and kind of fraught with difficulty finding agreement between different raters. And so the subjectivity of that endpoint really becomes an issue when looking at the data. Additionally, they point out in this PCICS podcast that there's not as much objective data to support the finding that low cardiac output was well treated by milrinone. And that comes from the no change in the AVDO2, the difference between arterial and venous delivery of oxygen. There was really no significant difference in the lactate levels for these patients at all time points. And so that kind of raises the question, like, well, is milrinone really all it's cracked up to be? And so this group looked at a more homogeneous population of patients who had undergone cardiac surgery rather than the large group that had many different kinds of surgeries in Primacore. This group looked exclusively at patients with tetralogy of Fallot. And they asked a question. So if a patient who underwent a tetralogy of Fallot repair received milrinone, were they more or less likely to receive fluid resuscitation? And they went with a very binary outcome. So if they got milrinone, did they get fluid, yes or no? And their findings were interesting. They found that patients who received milrinone, 66% of the time, they had to receive some fluid resuscitation in their postoperative course. And then only 50% of the time, patients that didn't receive milrinone did not receive, 50% of the time, those patients received fluid resuscitation. So patients that get milrinone need more fluid was kind of their takeaway. And that's not necessarily a bad thing, but it does kind of raise the question as to what's going on here, because it's very reasonable for patients to receive fluid after after cardiac surgery, but it's important to kind of understand what's going on. So getting back to that idea of these patients on milrinone had more hypotension and more tachycardia, they raised the idea that the mechanism of milrinone is certainly one that has many mechanisms, but notably it's a vasodilator. And when you talk about vasoactives, it's an arterial dilator. However, it's also additionally a venodilator. And so they raise the idea that perhaps these effects, these hemodynamic effects that we're seeing in patients on milrinone, namely, more tachycardia, lower blood pressure, and no change in your objective measures, maybe those are because you're getting less preload. And they do a really interesting discussion on the mechanism of how preload really works into this picture. And it really calls into question, that paradigm we looked at earlier. So, maybe it's not a plus, plus, plus. Perhaps the effect on preload is kind of not as simple as it seems, because certainly we still believe that milrinone helps lusitropy. It is a lusitrope. However, if it causes significant venodilation, you may not actually be getting good venous tone and good venous return back to that right side of the heart. So maybe that's hurting your cardiac output in a way. And so that's an interesting thing to think about. And I think kind of brings to light the fact that vasoactives are dirty and messy drugs. They have a lot of different effects, and it's important to understand those aspects when we're using them for our patients. And there's always a delicate balance of advantages and disadvantages. So what about other vasoactives that we use for low cardiac output syndrome? Well, there's a lot out there, and just as before we talk about that, I want to give a quick crash course or a primer on the types of or the classes of vasoactives we use, and that's namely for our purposes, these four here. So first of all, we talk about vasopressors, and those are medications that increase vascular tone, so make those arterioles squeeze down, and they raise your blood pressure by doing that. There's vasodilators. So vasodilators can make those blood vessels dilate and be beneficial because, as I said, they reduce the afterload against which a struggling heart has to pump. There are inotropes, which improve the contractility of the heart or the squeeze of the heart and make the heart eject more forcefully and get more blood out with each ejection or each heartbeat. And then finally, there's that concept of lusitropy, which allows the heart to relax more easily and fill better and then improve your cardiac output that way. So these are the main mechanisms we'll be dealing with regarding how vasoactives fit into this picture. And so this is a diagram that I think is more helpful for me personally in terms of understanding how these vasoactives come together and what are their varying effects. Because as you'll see, we have categories of vasopressors, inotropes, vasodilators, and lusitropes. And it's not quite so simple which category these medications fit into. There are some that really have singular effects, such as phenylephrine and vasopressin, or vasodilators such as nicardipine and nitroprusside. However, a lot of those drugs in the middle have multiple effects, and particularly milrinone, as we said earlier, it acts as both a vasodilator, an inotrope, and a lusitrope. So I encourage you to get your own framework for thinking about these medications. I've seen tables before where people try to express, the different characteristics of these drugs, but I find kind of graphically this to be a helpful tool for me to understand how these medications are working. So there's a whole host of medications out there that we can use. And based on what we described about low cardiac output syndrome, there's kind of a couple go-to ones that we institutionally use and you may be familiar with as well. But just know that there's different physiologies and different drugs to treat those physiologies. But institutionally, and I think very commonly, people will use a lot of epinephrine. As I showed in that Venn diagram earlier, epinephrine is a drug that is an inotrope, so it increases contractility. And in low doses, it's actually a very effective vasodilator. So that's a nice combination of effects because it's basically milrinone without the lusitropy is the way I like to think about it. So epinephrine is really a nice adjunct to milrinone, and it's very commonly used for patients who have low cardiac output syndrome. Additionally, if you have the blood pressure to do it, a lot of folks will use more milrinone to take care of their patients if they're not really having a good response in terms of using milrinone from the gun right out of the OR. And that's supported by the PRIME-CORE study. As they saw, high dose milrinone was found to be efficacious in reducing low cardiac output, whereas low dose milrinone was not. So if your institution tends to use 0.25 or 0.5 of milrinone, perhaps it's important to consider using a little more as that can be beneficial for some patients. I know in some centers, and perhaps this is falling out of favor now, some folks like to use dopamine as it has a host of effects, but it's kind of thought to be a more modest inotrope in terms of improving cardiac squeeze and perhaps more arrhythmogenic as supported by the sepsis literature. And so that is maybe less commonly used nowadays, but every center has its own practices, and there's a lot of ways to approach this in more than one way to skin a cat in terms of LCOS. So when we're using these medications and, remembering that Venn diagram is very busy and very crowded, we have to consider the downsides as well as the benefits of these medications. And I think it's important just to call out a few of those by name. And the main ones that I like to think of is that all vasoactive medications, at least particularly inotropes and certainly some vasoactives as well, increase myocardial oxygen consumption. So really, anything that whips the heart or makes the heart squeeze faster or harder or makes the afterload against which it pumps even higher, that's going to make the heart consume more oxygen. And certainly the heart receives priority, the lion's share of oxygen from the blood supply. However, there comes a point when you really may outstrip what the heart is able to receive from the coronary perfusion and may cause real problems in terms of ischemia or inadequate oxygen delivery to your heart. So you have to be mindful that when patients are getting higher heart rates, particularly in neonates above 160, 170, 180, you may be doing yourself a disservice by making the heart consume more oxygen. Additionally, when you're getting to those high heart rates, you have to remember that more heartbeats are good in terms of increasing your cardiac output. However, if you have a shorter period of diastole, you're not really going to have adequate time to fill your heart. And so there comes a point where such a short time in diastole will really start adversely affecting your cardiac output. And so we like to remember this when our patients are getting too tachycardic, is that they need time to fill that heart. Additionally, there's vascular tone to consider. And so patients who have different medications, these manipulate vascular tone in different ways. So if you do something like increase the afterload of your patient's heart by giving something like high dose epinephrine, you may actually make that heart work harder and worsen your low cardiac output syndrome. Even though in the short term, it's maybe helping your blood pressure, it can really get back to bite you in the long term because that heart is struggling and working against a higher afterload. And then on the other side of the coin, those medications that cause vasodilatation, such as high dose milrinone, can cause hypotension because of those vasodilatory properties. And so it's really important to be, aware of what your patient looks like clinically, what changes and what medications you've been using, and kind of follow and see what effects you're having by the interventions that you give to each patient. Additionally, because a lot of these drugs are in the catecholamine family, they all kind of bear a risk of arrhythmia. Even things like milrinone do have an increased risk of arrhythmia. And so it's important to be mindful of that, because certainly putting your patient into an automatic tachycardia will worsen their low cardiac output syndrome by an order of magnitude. And so we like to be mindful that our patient isn't in sinus tachycardia, or is in sinus tachycardia and not some sort of accelerated rhythm that's sometimes difficult to distinguish. And then one final word here is that patients who have preoperative heart failure may have some degree of tolerance of these vasoactive medications. And that is to say, they've probably, if they've been struggling with heart failure for a while preoperatively, depending on your lesion, they may have some downregulation of beta receptors on their heart cardiac myocytes. And so they may not be as affected by certain doses of vasoactives as some patients. So it's important to keep that in mind and know that every patient is individual and every patient responds differently to these medications and different doses. So that's our discussion on vasoactives. And before we get too far ahead, we'd like to just kind of get back to basics a little bit and talk about preload. And so preload is kind of relates to one of the foundations of interventions we do in critical care, and that's fluid resuscitation. This is used for many different pathologies, but no exception is cardiac surgery patients. So a lot of people like to use CVP to guide their fluid resuscitation. That's a reasonable thing, because it's a number we can trend, and it gives you a piece of information, and it changes based on the interventions that we do. And so I think a very reasonable approach that Dr. Ortman points out in her podcast is to give small aliquots of fluid. And a lot of people do this. You give 5 or 10 cc's per kilo of crystalloid, and you see what happens, because there's kind of a process where you have to do an experiment and see a response in order to see if you're helping your patient or not. And the reason to do that in that very judicious manner is because it's always easier to give more fluid, but it's difficult to take fluid away once you've given it. And giving too much fluid can actually cause a lot of harm in terms of, causing higher venous pressures, which impede your organ perfusion, and also stretching on the heart and causing, worsening heart function or worsening valvular insufficiency in certain pathologies. So we have to make sure that we're not causing cardiac dilatation by giving fluid overload. And we have to give it little bits at a time to see how this patient responds. And that's supported by, one of the foundations of critical care literature, and that's the Frank Starling curve. So many people will know this curve and be familiar with the concept that giving preload or increasing your right atrial pressure can increase your stroke volume. And that's a phenomenon that we see both in patients who have normal contractility or augmented contractility, as you can see on the A and B lines here. And that's a really important, concept to have in your brain, because we do know that making those myocytes stretch, kind of priming that spring, stretching that spring of the heart muscle out by loading it with fluid, not only puts more fluid in the ventricle or puts more fluid in the heart to be ejected, but it also kind of makes that contraction more forceful due to that concept of, the stroke volume curve. So, but I think one important thing to point out is that CVP is not the be all end all. Again, I'll get on my horse about this, but CVP is not just a measure of volume, but also a measure of compliance. And that's a really important concept that I think we tend to forget when we're resuscitating our patients. And that is really because we can look at this graph, which on the x-axis talks about LV volume, and on the y-axis talks about LV pressure. So you can see that patients who have a normal compliance of their heart muscle see kind of a dose curve response. When you give a little bit of fluid, you get a pressure increase kind of in this mostly linear fashion. But when you have a patient with a non-compliant myocardium, such as a patient with tetralogy of Fallot, is kind of the hallmark or the poster child for that disease process, you can see a rather large spike in your pressure with a same amount of fluid bolus as you might give normally. So I think that's a really important concept to keep in mind, is that, CVP is not just a measure of intravascular volume. It is a measure of the compliance of the heart, the compliance of those chambers that you're filling. And so, a CVP of 8 is not the same in all patients. For example, you can have a patient who has a CVP of 8 and they could be rather replete with fluid if they have normal normal heart compliance. But if you have a patient who has, diastolic dysfunction, such as tetralogy flow, if they have a stiff heart that has trouble relaxing, their CVP of 8 may not mean that they're replete with fluid. It might actually mean that they're underfilled. And so we rely on our kind of judgment and the OR teams to kind of tell us, what is the ideal optimal CVP? Where does this patient have the best blood pressure at? What is their good CVP? And that number will change, but it's good to have, a working kind of framework to think about where does this patient like to have their CVP in order to augment and optimize their cardiac output. So that's talking about fluid resuscitation. And then I wouldn't want to finish without just addressing the stepchild of kind of LCOS treatment. I think that's really RV afterload reduction. And so, we tend to think in terms of vasoactive support a lot about LV afterload reduction, but it's important to remember that oftentimes the RV is struggling as well. And so the way we can help that RV and reduce its afterload specifically is by doing anything that will reduce your pulmonary vascular resistance or your PVR. And so I think there's a couple key measures we have to think about here. There's lung recruitment if you have a patient who has some sort of lung disease or atelectasis, because we know a derecruited lung or a lung that's not recruited up to FRC or the functional residual capacity, that patient will definitely have increased pulmonary vascular resistance. So even though these are cardiac patients, we have to think about their lungs as well sometimes. Additionally, we can think about different pulmonary vascular vascular resistance reducing drugs, such as nitric oxide. Obviously, that's a great medication because it acts locally. It doesn't have a lot of systemic vasodilation. It just works really specifically on those pulmonary vascular beds and reduces PVR, which can really be a boon to the RV function. And then finally, the easiest and cheapest pulmonary vasodilator around is oxygen. So just giving oxygen, not only helps your oxygen delivery to your body, but helps the mechanics of your RV as well. So those are really valuable measures in terms of reducing the afterload to your right ventricle. Now, those are the ways we think about kind of augmenting the delivery of oxygen, but I would be remiss if I didn't mention the other side of the coin here as well. And that is that low cardiac output syndrome is really essentially a shock state when it comes down to it. And shock, for those who know, is really an imbalance rather, between the delivery and the extraction of oxygen. So it's about that delivery of oxygen, DO2, and extraction of oxygen, and VO2, and the relative ratio of those. And so if you've done everything that you can to really augment delivery of oxygen, it's important to think about, well, what am I doing to kind of minimize the extraction of oxygen from my patient as well? And so, this is simple stuff, but it really can serve as a benefit for your patient. And that can take the form of things like antipyresis or keeping their fever down, treating, pain, treating agitation, and in some cases, treating seizures. These are all processes that consume an inordinate amount of oxygen and energy when a patient is having a fever, when they're agitated, when they're in pain, when they're having a seizure. All these things can really affect your delivery of oxygen. That's why sometimes patients require, good scheduled antipyresis, where they require deep sedation. And it's important to keep these things in mind when you're thinking about the whole picture. So finally, I just want to circle back to the concept that we touched on at the beginning about the etiology and the pathophysiology of low cardiac output syndrome as an inflammatory condition. So that's the understanding of it, and that's what the evidence shows. So the question is, if it's inflammatory syndrome, well, should we give anti-inflammatories to treat it? And a lot of people have thought about this and used this in practice for years. And in particular, methylprednisolone is thought to be one of those kind of big gun steroids to blunt the inflammatory response. But however, the evidence doesn't really show clear benefit. And certainly we know there are side effects with increased risk of infection, hyperglycemia, and hypertension. And I can say that there's no clear benefit based on this kind of more recent trial from New England Journal of Medicine, which was called the STRESS trial. This is a great trial, which wasn't around in my training days, but is available now and gives us a really good answer to the question about using methylprednisolone for these patients to prevent low cardiac output syndrome. And essentially, what they did in this trial is they randomized 1,200 infants to either receive methylprednisolone or placebo. And what they found is that there was no change in the composite outcome of death, of needing extracorporeal life support, of needing a heart transplant, length of stay, or any organ dysfunctions. And so that was really valuable information in terms of thinking about, one of these adjunctive therapies that sometimes people employ taking care of low cardiac output syndrome patients. So finally, I just want to talk and give a word about premature closure, because you take care of patients and we have a concept in their mind. We've made the diagnosis of low cardiac output syndrome and we treat them accordingly. And sometimes they get better, and hopefully they do, usually in that 24-hour time period. But if they don't, it's important to be aware of this concept of premature closure. And that is the idea that we make a diagnosis and we kind of go down a path with blinders on, not thinking about the other possibilities that could be at play here. And so, generally, if we treat a patient with low cardiac output syndrome appropriately, and they get out of that 24-hour period, they should start to get better. But if they're not getting better, then it's incumbent upon us as providers to really think about what else could be going on and what is happening to this patient if it's not low cardiac output syndrome. And that can take the form of many different things. Like I mentioned earlier, we can think about certain arrhythmias. Tachyarrhythmias can really be difficult to diagnose sometimes, and they can be rather subtle. And so it's important to think about things like JET or other automatic tachycardias, which can masquerade as sinus tachycardia. There can be things like bleeding, and that's not always readily apparent because we rely on chest tube output a lot to give us an idea of how much a patient is bleeding. But certainly, if your chest tube output is low, it may be a sign that your chest tubes are clogged. And so, if your patient is slumping and your chest tubes aren't draining, it's worthwhile considering if your chest tubes are clogged, if you're developing some sort of restrictive physiology or tamponade, because that can be basically a cause for severe decompensation. Additionally, sometimes patients have a residual cardiac lesion. So, there can be some sort of physiology not accounted for in our postoperative care, and something that may need to be readdressed. And that's important to consider in your differential diagnosis. And always have a conversation with your surgeons about, if your patient is not progressing as you expect them to. Additionally, although we don't really tend to think about coronary pathology in pediatrics as much, there are certainly some surgeries where the coronaries are heavily involved, where they're excised and reimplanted. And we have to be cognizant that patients who have ineffective cardiac performance may have bad coronary perfusion. And so it's important to keep that in mind and, monitor our EKGs, monitor our telemetry, and consider this, especially in certain lesions. And finally, even though we just got done saying that steroids aren't really prevention or a good treatment for low cardiac output syndrome, we do know that some of our patients are more at risk for adrenal insufficiency, particularly in neonates. They don't really have that reserve of stress steroids that they can manifest when they're in a critical and stressed state. And so, it is very commonplace to check a cortisol level and to give stress dose steroids, because even if your patient does not have adrenal insufficiency, giving high dose steroids will almost always raise their blood pressure. You just have to be willing to live with the side effects that we discussed earlier. So in summary, I think it's just really important to make a mental model of the patient with low cardiac output syndrome based upon the data at hand. And that data should really not just be one singular number. We like to put the entire clinical picture together, how the patient looks, what are their labs, what are their vital signs, and then just kind of use that in conjunction with your framework, your understanding of how cardiac output works and how that's deranged in low cardiac output syndrome. As I said, it affects preload, contractility, and afterload all in this kind of complex interplay of all these factors. So you want to think about your working model, your mental model of this patient, and then as you're taking care of the patient, you always want to reevaluate your hypothesis. If you're giving fluid, if you're giving vasoactives, and the patient is not responding as you might expect, it's important to kind of reevaluate and not come to premature closure, because there's other things at play. These are complex patients, and they're afflicted by many other things apart from low cardiac output syndrome. But I think if you have an understanding of this kind of basic framework, you'll be in a good spot to really take great care of your patients